Good morning. Thank you. Welcome back to the conference, and I hope you enjoyed yesterday and you have a lot of wonderful ideas and some new thoughts to take back to your organizations, and knowing that today and tomorrow will certainly add to that. It's my pleasure right now to call Peter Carter to the stage, who really needs minimal introduction. But as you can see from the slide, we're going to be presenting Peter with the Life Membership Award. So let me just read you a summary of Peter's contribution, amazing contribution to quality in healthcare. Peter has worked in healthcare quality and safety in developed and developing countries for over 30 years. His particular areas of interest are organization for quality improvement, education, innovation, the challenges of an aging population, and resourcing developing countries to enable quality enhancement. At the end of 2008, Peter became the acting CEO at ISQua, and this was shortly after we had relocated from Australia to Ireland, and was appointed then CEO from 2011 for 5 years. During this time, ISQua underwent expansion, including the development of new programs such as education, low and middle income countries, and innovation. For 16 years, Peter was CEO of the Specialist Medical Colleges of Psychiatrists and Surgeons of Australia and New Zealand, working to incorporate quality improvement into training programs and professional development and building research capacity. Peter's consults with a focus on healthcare quality and education and advises on quality management. Peter was recently appointed mentor and patron of the Africa Institute for Quality and Safety and Accreditation, whose job it is to address capacity gaps among frontline healthcare workers and healthcare providers in healthcare in quality and safety. Peter has been made a companion of the Royal Australasian College of Surgeons and awarded Alumni Achievement of the University of New England. He is currently a board member of ISQua. I am delighted to award the Life Membership to Peter for his service to ISQua and his commitment to improvement of quality and safety for healthcare globally. Oh, just Peter. Peter. Over to you.
Thank you, Wendy, and congratulations again, Peter. Well, welcome to the plenary session for the second day. Also happens to be the second last day. What a fantastic start we had yesterday. That was preceded by the pre-conference workshops, of course. And you've all fronted up today full of enthusiasm, I'm sure. And we have quite an interesting session for you this morning. We have two interesting speakers. Our first speaker is Sandra Chakoti, who is going to be talking to us about quality improvement and my recovery, a road less well travelled. I was talking to Sandra just a little while ago about her impressive CV and introductory remarks, and she said, "I'm here just because I'm a patient." Actually, Sandra, you're here not just, but really because you are a patient. Sandra has had a successful career as a solicitor and a partner of a law firm in London, with many years' experience working both locally and internationally. She's had many achievements during that career, but she was awarded an Improvement Leader Fellowship in 2016 with the National Institute of Health Research Collaboration for Leadership in Applied Health Research and Care. ISQua believes itself to be a scientific organisation, and therefore hearing from people like Sandra about their journey as a patient, as the very reason we exist, is really the purpose of this seminar this morning. Sandra, can I welcome you to the podium? We look forward to what you have to tell us.
space. Good morning, everyone. Thank you for having me here today. Today, I feel very honored to be standing here on this podium to deliver a keynote presentation. For those of you who may know, I'm also one of the 10 recipients of ISQua's Patient and Public Scholarship Awards for this year's conference. Thank you, ISQua, for the scholarship and giving me the opportunity to present a keynote here today. Hope you have no regrets after hearing my keynote. Over these 4 days, you would have heard and will hear presentations from speakers predominantly from medical background. I'm here just as a patient today, a patient on her recovery journey. I will not be delivering facts and figures, run charts or graphs. You would have had enough of that already. I want to tell you a story, my story, which many patients and public will also share. A story that I hope will open your eyes for the plights of people like me, people with a severe mental health condition. Chapter 1. I was born in this vibrant country, Malaysia, a country where I spent the best part of my life, from walking barefooted in the streets and crossing rivers with school bags over my head, building tree houses and falling down 100 times, climbing trees, which I still do, but not taking the risk of hanging upside down anymore. My sisters identify me as someone who refuses to grow up. I still feel there is this little girl in this body. I was a natural leader, so I was told when I was a child. If I think back, I could con any friends to doing anything I want. Childhood was the best days of my life. However, even then, I was wearing a mask. There was sorrow behind that happiness. No one knew. I left Malaysia when I was 30 years old to UK to pursue further studies. Chapter 2, a road less traveled. For those of you who may be wondering, did I pick my topic based on Robert Frost's poem, The Road Not Taken? No, I did not. I only came across it when I was Googling for images to make my slides come alive. I found this poem and it read, and I was pleasantly surprised how the last 2 lines resonated with my topic today. I took the one less traveled by, and that has made all the difference. I took the quality improvement road. However, this road is still less traveled by the providers of mental health care, and even less so by the service users and carers globally, or patients and public globally. I decided to talk on the topic of mental health and quality improvement because it was my involvement in quality improvement work which ultimately turned my life around. Can I please do a show of hands as to how many of you have traveled for this conference are providing mental health care? Can you turn around and look around, please, to see, so that you can know how many are providing mental health care? Please raise your hands as high as possible. Right. We have almost, I think I can say, about 200 people in this hall, and there's hardly less than 10 hands up. What does that show you about the interest of people with mental health inequality? This conference did not specify it is for people who want to improve physical health care. It's for anyone who wants to make an improvement. They improve the quality of service they provide. Yet we do not see that many take from the mental health sector. The same goes for the number of sessions on mental health and poster presentations here. They are significantly lower than that of physical health representations. I was happy yesterday when I heard the Sultan of Perak, the state I was born in, mention in his keynote yesterday a couple of words around the emerging mental health problems. Chapter 3, the gap. We read about the rise in mental health problems in our countries, yet we do not see the same acceleration when it comes to supporting mental health services. Studies have suggested that mental disorders rank among the most substantial causes of death worldwide. Mental illness has been assessed as constituting around a quarter of the disease burden in developed countries. There is much bigger treatment gap for mental illness than for physical illness. We also know that physical health problems can also lead to poor mental health care. Our physical and mental health are inextricably linked, and people who live with long-term physical conditions such as cancer, diabetes, arthritis, or even asthma are also likely to experience mental ill health such as depression and anxiety. Long-term conditions can't be cured, only managed, and they come with the risk of social isolation, low self-esteem, stigma, and discrimination. This can easily give way to a mental health condition if support isn't available. So what role do you play as physical health care providers to support these long-term condition patients? Signpost them to a psychiatry team, or do you also take an interest and play a part in their mental health care? There's a wide gap between mental and physical health care. This disparity of esteem is much wider in low and middle income countries. It is only in recent years some countries even recognized mental health as a disability. In some countries, even including Malaysia and India, as of today still do not have medical insurance coverage for mental illness. Chapter 4, why it matters. Mental health matters to me because my brother, whom I love dearly, and I suffer from severe mental illness. It matters because my late grandmother suffered from psychosis. It matters because it robbed a good part of my life and my brother's life. It matters because mental health patients want to receive the same level of health care for both physical and mental health. I have friends all over the world, and this inequality upsets me. It matters because I had the opportunity to take the road less traveled, i.e. be involved and live a life that has meaning. It matters because my brother is still in the dark, and it hurts me. The mask. You can't tell how much suffering is on the face that is smiling. Following the completion of my studies in UK, I decided to settle there permanently, got married, have a beautiful princess who is the love of my life. I practiced as a solicitor and then went on to set up a law firm. I thought all was well, but it was not. But only to realize I was still wearing the mask. The mask covered what was going on in circle in my head over and over again. But when alone, the pain was unbearable. My first episode of depression and anxiety was in 2000, just when my daughter was a year old. The fear of stigma made it worse, as I could not share it with anyone. I was seen as a pillar by my family and friends, and I was going to maintain it at all costs. The battle continued for a long time, and I was determined to fight it on my own. However, in 2007, things got worse. I was hearing voices, mostly derogatory ones, about how worthless I am and that it was not worth living anymore. Voices were telling to kill myself. My relationship with my then husband was at breaking point. My daughter, bless her, was constantly subjected to verbal abuse from me. I was always shouting at her. This was not my normal behavior. I was a qualified solicitor and a partner of a law firm. Staff who once respected me would shy away from me for fear of my anger. I took myself to my GP as the suicidal thoughts kept increasing. He suggested I should see a psychiatrist. It took him a long time to convince me, but I did in the end. Then here again, I was all alone in my battle. Finally, I was admitted in the hospital for 4 months. I was the lucky one. I had private medical insurance. I was diagnosed with bipolar, psychosis, adult ADHD, and post-traumatic disorder. It's like I had given the psychiatrist a blank check. The domino effect. They say when bad things happen, they happen in a row. Well, mine did. Following the admission, I lost all the will to live. I lost my law firm. I was divorced. That's the best thing that happened. I was made bankrupt. My house was repossessed. And my psychiatrist signed me off as unfit to work. And that really killed me, being unfit to work. At one point, I was even made homeless because the estate agents would not rent me the properties because my credit rating was bad. And even though I was offering 6 months rent in advance, it didn't matter. So, hey, what's the point of living anymore? There was no reason apart my 8-year-old daughter at that time. The drugs made me a zombie. Waking up time was 11 a.m. I do not know how I managed it today, but normally I would be still sleeping at this time. I could not think straight. The medications were making me eat and put on weight. I told my psychiatrist I can't stop raiding the fridge at midnight as I feel so hungry. He told me to put a chain around the fridge, but he forgot to tell me where to keep the key. And this is true. I thought he was joking. Then I took it to my psychologist, and she asked me, did he tell you where to keep the key? I was a wreck, but nobody saw my pain behind that mask. Wash my brain. One of my favorite starting points when I visit my psychiatrist or psychologist in the beginning was, please wash my brain or recalibrate. I can't take the pain. I have become this different, lifeless person, hardly recognizable. And my psychologist told me, you're not the only one who comes and tells me to wash my brain, wash their brains or recalibrate. Personal hygiene was out of the window. I used to cross over the other side of the street and sit far away from people who looked scruffy and had an odor. And now I have become that person. I never thought I will see that day where I am on the other end. My daughter would ask me did you brush your teeth, Mom? Go have a shower, Mom. Stop eating, Mom. I was unwell, and I could hardly take care of my 9-year-old daughter well-being, and yet she was concerned about me. I sent her to live off with my mother in Malaysia for 3 years while I was traveling back and forth. She was not very happy with that, but she had no choice. My highs and lows continued. When I thought my world was about to close on me and it had no meaning, I saw hope in the form of quality improvement work around mental health. From my own experience, quality improvement is about recovery, my recovery. As a service user involved in various quality improvement projects, policy making around mental health helped me find a meaning in life. Fortunately enough, I had a good therapist who worked with me. After a year into therapy, she suggested I did a bit of volunteering and attend some recovery and well-being courses where I learned about co-production and patient and public involvement in research. After completing the course, I put my name down for opportunities to be involved in research work. It was known as patient and public involvement. At this point of my life, was still full of anxiety and I was struggling. In June 2014, I joined a multidisciplinary QI project team as member with lived experience of severe mental illness. Sorry, they are not the ones. I just took that from Google Photos. I was searching all my photos, I couldn't find them. So. The project was about improving physical health assessment for people with severe mental illness. This project gave me the platform to come out of my shell. This was the first time after my diagnosis I went into London as I was afraid to take the public transport. I was afraid I might kill myself by falling onto the train tracks or before a bus. There was a routine, at least for me, at least for a fortnight. I was amongst professionals, which I was missing since I was signed off unfit to work. Nevertheless, there was still anxiety and worries in the beginning. I felt left out for over 2 months because I could not say much in the meetings. I think both the professionals and the service users in the team were unsure of how the patient and public involvement is supposed to work. It evolved over time. When the relationship between the service users and staff began to improve, so did the contribution from the service users like me. However, there was one service user who could not contribute during the meetings, but did so on a one-to-one basis after the meetings with the staff, and that was how he felt most comfortable. The team continued to involve him in the manner where he felt comfortable. I also came to know that the rest of the staff, from the consultant psychiatrists, nurses to pharmacists, saying that they've never saw service users in this capacity, working together with them in an improvement project. We, through our involvement, taught the staff about gaining insights to service user involvement. Chapter 10, I'm sure it's going to be finished soon. For the first time after 14 years of my diagnosis, I learned that my life expectancy can be shortened. This was devastating news. For people with severe mental illness are likely to die 20 years younger. The first thing that came to my mind was my daughter, the love of my life. Would I see her graduate or walk down the aisle? Would I see her children? I was already in my 40s when I had her. So that is another disadvantage. I was determined to teach her to be independent as soon as I can. I also learned that I needed to take care of my physical health and understood how to do it well. Having regular physical health assessment was one of it. I joined the dietary groups about healthy eating and weight loss. You know, your weight goes up and down. If you think I'm big now, you should have seen me a year ago. I learned what QI methodology is. I learned about PDSAs, action effect diagrams, or some call it driver diagrams. I learned about process mapping, which I'll be co-presenting tomorrow with a colleague. I learned to design leaflets and booklets using plain English. You think this is plain English? That was even plainer. I learned about measurements and data. I gained confidence to make suggestions and challenge the team if implementations did not take place. I was not afraid of being vocal. But sometimes my passion can come out very strongly within me and wonder if I was displacing manic or psychotic behavior. The best thing is that we co-produced the patient health booklet and video on physical health assessment. We contributed to the design of a single multidisciplinary health assessment form. The opportunities. Being involved in the QI project helped me to get scholarship to do an improvement fellow with the National Institute for Health Research in collaboration in leadership in applied healthcare. I'm now doing my own piece of PDSAs, Plan, Do, Study, Act, around the effectiveness of the physical health assessment booklet. I'll be doing a qualitative interview with the patients who have received the booklet. This led me to my first paid employment in 9 years with the East London Foundation Trust as a service user advisor for a research project. I attended a course on qualitative interview. I was involved in the designing of a mental health policies with the Royal College of Psychiatrists. I now sit at the Central Northwest London Quality Improvement Program Board as a service user advisor, and a service user advisor and carer in involvement in QI projects. I've traveled and presented at the mental health hospitals in Malaysia and in Singapore about my recovery journey. I have presented at the World Psychiatry Conference in Berlin last year on peer support. But the most rewarding bit that came out of my involvement in quality improvement is knowing that I'm not alone in my recovery journey. I have support that I can tap on, both from the Quality Improvement Project team and the Clark team, who were here today. They included consultant clinicians, patient and public involvement leads, lecturers, and PhD students. They helped me with application forms. I was so ill that I could not even fill in an application form for my job, for the improvement fellow, and even to get to this conference, I was so anxious. I have to call someone, can you help me fill in the form? For giving me valuable feedbacks, and most of all, encouraging me and believing in me. They offered their time selflessly. I'm standing here today without my mask. I'm not ashamed anymore of my bipolar or psychosis. My take-home message for all of you is that mental illness is nothing to be ashamed of. Stand up and fight for the rights of your patients, for the rights of people like me. Share what you heard today with your colleagues from the mental health sector. You can make a change in their lives of people with mental illness. Involve them in your quality improvement work, be it mental or physical health. Quality improvement projects or sitting in board meetings or on your interview panel. You can involve them as little or as much as you want. We are a valuable resource that you should not let it go to waste. Get us involved in your improvement work. Support us, guide us, train us, educate us. You understand us better. You may say, I'm not paid for this and I don't have time. But easier for us to ask you to spend that extra time with us because you know us. You know our condition, and most of all, you do not judge us. When you learn from us, it builds our confidence. When you appreciate what we do, it keeps us motivated. When you publish what we have contributed, it makes us proud. When we are not involving as much as we should, don't ignore us. We might just be anxious. You can make that difference to the road less well-traveled. A road less traveled. The princess, the love of my life, and the reason I'm alive. Thank you.
Sandra, thank you. Thank you for so much that you've shared with us this morning. We have to acknowledge your honesty. We have to acknowledge your courage. your humility. A bit of humour there too. I think that makes it just ever so much more bearable, doesn't it?
Yeah.
But thank you for being a leader. As a patient, you have led us into new insights into what we are supposed to be doing as we run health systems, as we interface with patients, as we interface with our families. And we wish you and the love of your life all the best for the future. And I have a small gift to thank you for what you've taught us today. And I'm sure there'll be many people who'd like to talk to you over morning tea about your experiences. And if you've got experiences to share, I think the lesson is share them. Seek help, because there are people who've been through the same experiences. Would you thank Sandra?
Thank you.
That's marvellous. Thank you so much.
Thank you.
God bless you.
Want to take a picture?
Oh. Marvellous start to the day, was it not? We're going to be honoured now to hear an address from the Director General of Health in Malaysia. Datuk Nur Hisham Abdullah is well respected not only as administrator but as a clinician without peer. He is a surgeon, particularly focusing on breast and endocrine surgery here. He is recognised around the world for his work. He has a fellowship from the Royal College of Surgeons in Edinburgh and also one from the Royal Australasian College of Surgeons. Apart from his active involvement as a policymaker now, he is involved in global organisations such as WHO and the Drug for Neglected Disease Initiative. He's also a councillor at large in the executive board of the International Society of Surgery, and he chairs the Global Surgery Committee of ISS. His special interest lies in enhancing the accessibility and affordability of universal healthcare coverage through digital technology. Innovation to bring personalised healthcare back to the community and the home. What an all-encompassing challenge that is. Would you welcome the Director General to the podium?
Assalamualaikum and good morning, everyone. And first and foremost, I would like to thank the Chairman for the kind introduction. I would like to thank the organizing committee for giving me this opportunity and the podium to talk on the driving quality with innovation and creativity. Now, let us look back in time. In 1978, 40 years ago, the International Conference on Primary Healthcare came together, and all health and development workers and stakeholders talk about to protect and promote the health of all people in the world by year 2000. And the concept of health for all, leaving no one behind, was mooted. And health is a very important universal human right, and to reduce the human misery and suffering, as well as the advances of equity, safeguard, and human dignity. This is the concept that we embrace over the years, but we ask ourselves, looking back in time, what have we done? This framework, what have we actually implemented over the years? And this is important for us to look back in the time and look in the future and the present. What should we do? Health is wealth, and healthy population is important to translate productive and stable nation. Universal health coverage was mooted 40 years ago, which is a pragmatic and ethical ideal approach to achieve productive nations closely linked to the social and economic progress, leaving no one behind, leaving no community behind, leaving no country behind. The minimum ideal is that no individual or family should suffer for financial hardship because of accessing to good quality medical assistance. Now, health for all, universal health coverage covers a social system that provide medical and non-medical services and infrastructure that are vital to promoting public health. And UHC highlighted the power of the primary healthcare and international cooperation to advance the protection and promotion of health in resource-constrained countries. So we are embracing health for all, leaving no one behind. Now, WHO and World Bank offer a relative simple UHC service coverage index that is useful for inter-country comparison. And the index focuses on 4 categories of health indicators. First, the reproductive and maternal child health. Second, communicable diseases. And third, non-communicable diseases. And most important, looking into access of services and access of medicine, as well as services capacity. No one is left behind. Now, when we look into the definition equality, whereby the assumption is that everyone is equal, giving everyone benefits from the same support, equal treatment, and whether you can access to healthcare treatment. For example, the T20 will have privilege and opportunity to access to good quality of care, and M40, but the bottom 40 may not have a good access to the healthcare system. But today we are looking into equity. Everyone gets the support they need, thus producing equity. And this is what the T40, T20 supporting the B40. And the most important, if we can have the social justice, all 3 can see the game or access to healthcare without supports of accommodation because the cause of inequity was addressed. The system barrier has been removed. This is the concept that we need to embrace to provide good universal health coverage. We talk about the coverage, but in time to come, we also need to look into the quality of care, not only the coverage. Poor quality of healthcare was a major driver to access mortality across conditions from NCDs or even CDs. And universal health coverage for Sustainable Development Goal could avert 8.6 million deaths per year, whereby 5 million have poor quality of care and 3.6 million have no access at all. And this is where I think when we talk about universal health coverage, most of us start with a very basic coverage, basic healthcare services, but we do know that it's important for us to improve the quality of care top down and have a good framework for us to pursue and propel healthcare to have good quality in the sense that this is as what been published in Lancet in September 2018. We came up with the concept of Sustainable Development Goal, whereby goal number 3 is good health and well-being. But if you look into all the goals, 17 goals, directly or indirectly, they have an impact on healthcare, which means every sector is indeed a healthcare sector. Let us look in our country, the journey of healthcare. We started with a very basic healthcare services in the past. And for us to evolve further for the future, we need to understand where we were in the past, where we are now, and what we plan to achieve in the future. So how do we envisage our healthcare in the future? And back in time, from the basic in 1960s, we were focusing mainly on maternal and child health, communicable diseases, and advanced in 1980s, and we add on in dental, pharmacy, and laboratory services. And in year 2000, we add on the NCDs as well, and we continue to evolve our healthcare until today. But more importantly, how can we improve? Although the universal health coverage is available in this country since 1960s, but more importantly is that we have to focus on quality of care, not only the basics. Now, I have the opportunity to accompany the Regional Director of WHO, Dr. Shin, to our rural healthcare, remote healthcare in Borneo, as well as to look into our healthcare in the urban area. And he made the conclusion, and I quote, Malaysia has successfully managed to develop a modern, comprehensive, and efficient healthcare system, even though we only spend a GDP of 4.5 or 4.6% overall for the last 20 years. And Malaysians should realize how lucky they are to have such a very comprehensive healthcare. In the public sector, our GDP is only 2.3%, and in the private sector comes another 2.2%, of which total is about 4.5%. But more importantly is that how can we improve the quality of care and with a reasonable cost? So this is a very important subject matter for us, looking into evidence-based medicine. how can we translate evidence-based medicine and transform them to value-based medicine, whereby the costing is equally important. With every dollar that we have investment in our framework of the healthcare system, we hope to have the maximum outcome. And when we look into the resources that we have in the public and private sector, there's unequal distribution, whereby you look into the health clinics in the public sector, it's only about 10%, 90% in the private sector, the GPs. But again, majority, about 60% of the population still come from public sector, public health clinics, which mean the public health clinic is very congested. And what about the hospital? Looking into the hospital and public sector, we have 153 beds, 153 hospitals, and we have more hospitals in the private sector. But again, the hospital beds and the hospitalization is much more in the public sector. Again, this shows that there's unequal distribution of the resources and human resources and infrastructure, and by then very congested in the public sector. But how can we, address this issue of inequality in terms of the access of healthcare, in terms of infrastructure in the public and the private sector coming together to have an equal distribution, whereby the expenditure is almost the same from the public and the private sector in this country. And over the years, you can see our GDP has increased very slowly to 4.5% to date. And again, this is one of the lowest GDP in the world, but trying our best to have a high impact, good quality of care with a very low, reasonable GDP. And over the years as well, we have seen the sustainable, substantial decline in over the 3 decades after independence. The infant mortality rate, neonatal mortality rate is coming down, but we have been stagnant for the last 20 years. Again, we are looking into how best we can improve the system that we have. Perhaps our system was designed and the framework was to look into the public health, mainly in maternal and child health and also communicable disease. But we ask ourselves whether our system is able to cope for NCDs, aging population, and the rising healthcare costs in this country. Is our system today sustainable? Because basically in the public sector is funded by the government, and we also have the private sector mainly coming from out-of-pocket payment as well as insurance. Now, looking into the trend of the non-communicable diseases, the rapidly growing prevalence, the diabetes actually has increased for the last 30 years from 6.6% to 17.5%. Hypercholesteremia is also on the rising trend. Hypertension is about 30%. And we are looking into how best we can improve the quality of healthcare with minimal costs. And this is where we are embracing the value-based medicine, and we need a value-based research to support the evidence towards quality care, high impact, high quality services with reasonable costs and high patient satisfaction and accessible and affordable to our population. These are some of the principles that we have embraced over the years. Evolution of healthcare quality in Malaysia. First, quality initiative driven by the patient. So we do have the Patients for Patient Safety initiative been done since 2013. Quality initiative driven by innovation and creativity. We believe that creative ideas and innovation can improve the quality of care and bring down the cost. And more focus on specific quality initiative, for example, the incident reporting, etc. Continuous monitoring of our data and performance in our hospital, in our clinic, and etc. Even individual performance of our clinician. And systemic quality assurance program started way back in 1985. Individual quality professional development, for example, monitoring the direct and indirect measurements of the clinician to ensure the quality is being in place. Now, quality can be top-down and also bottom-up. And it's important for us to listen to the patients and see how best we can improve the quality of care. In this day and age, information technology, we need to engage with our public. We need to explain issues and challenges. We need to create the expectation of the public of what can be done and what cannot be done. And if we can deliver beyond the expectation, then we will win the public trust and confidence in our healthcare system. This is day of information technology. Using the social media for engagement is one means that is a high impact, reasonable cost, and perhaps no cost at all. But you get a high maximum communication and engagement. So this is important for us to embrace in time. And when we look back in our healthcare journey in terms of quality, in 1980s to 81 to 85, we have a fourth Malaysian plan. Our emphasis then was on quality and coordination of quality-related activities, and QAP, quality assurance programs, was introduced in 1995. Then in 1986 to 1997, emphasis on the improvement of services. Program-based national indicators were formed and developed, and the patient care and public health care laboratory services, etc. So we try to measure and impact, once we have the measurement in place, the basic measurement in place, and see how best we can improve over a period of time. So we introduced the health technology assessment of our equipments, whether the investment, there's a return on investment in terms of benefit for our patients, and a pre-operative mortality review. And in 1998 to 1999, we talk about strategic plan for quality of health in our healthcare system, accreditation of our hospital by ISQua, and incidents reporting and learning system for our healthcare providers. And in year 2000, we moved on to hospital infection control, patient safety council, KPI for accountability, and we move on to 2005 to 2010, evaluation of quality assurance program, more structured complaint management system in place, client charter, and innovation. Again, our healthcare system is, we need to listen. When we have a complaint, perhaps that complaint will be our guidance for us to improve further. And this is, again, engagement with the public, engagement with our patients, listening to what can be done and how can we improve with the limited resources that we have. In year 2000 and 2015, we focused on safe surgery, Malaysian patient safety goals, lean initiative, maximize the utilization of resources, looking to the processes. Some of the processes we have in a clinical practice already obsolete. Can we re-look back again to maximize in terms of waiting time, in terms of improving the outcomes of our patients, not increasing the resources, but just look into the structure and the processes. And also we look into maximize the utilization of resources that we have, rather than ask for infrastructure that we do not have, maximize whatever we have. For example, the district hospital is underutilized. BOR rate is actually, BOR is less than 30-40%, and the state hospital is all congested. Now, we came up with these ideas of cluster hospital, which means the clinician is equally responsible for the district hospital, taking some of the services down to the district hospital, and we have maximized the utility and usage of the district hospital. Operating theatre, for example, in district hospital, all our district hospitals have at least 2 operating theatre, but over the years, because of the lack of human resource and doctors and specialists, underutilization, and some of the operating theatre became a storage room, and etc. So that is a waste of resources. Now we maximize the utilization of the district hospital, and that would increase in terms of our efficiency and the quality of care. Then we also embrace the outcome-based budgeting, and we have introduced pain as a fifth vital sign, pain-free hospital concept, baby-friendly hospital, patient for patient safety initiative, etc. And from 2017 to now, we look into the mandatory patient safety course for house officers, for example, near-miss reporting incidents included, and root cause analysis and action plan. So these are some of the initiatives we have been doing over the years to look into, apart from universal health coverage, how can we, looking into the big framework of healthcare, providing quality top-down. And we only can provide the framework, but it's also equally important for us to get the response from bottom-up. And each and every one of us, each and every department, every hospital and every clinic will have to give the feedback for us to improve the quality of care, because we embrace that evidence-based to value-based. And some of the initiatives that we have done, we also need to look into the processes, how best we can come up with outcome, with better outcome with limited resources. So these are some of the activities we have done under our patient safety Malaysia. We have conducted the first inter-country workshop, National Healthcare Leaders Summit, and etc. to actually create awareness. But this is the more important is the innovation and collaboration. We believe in time, today and the future, that healthcare will be driven by quality of care. And the quality of care based on our innovation and creative ideas. These are some of the ideas that we have and have been implemented. For example, taking surgery from the hospital back to the community. Is it possible? Have we done it before? Yes, we have done it over the years. For ritual mass circumcision, has always been done in the community, not in the hospital. And when we look into cataract operation, and I used to see cataract operation being done in general OT under local. So it's a waste of resources because you're wasting my general OT time. And what we have done is we look into converted a shop lot to 2 operating theatre. And in normal operating theatre under local, my specialists can do about 7 cataract operation a day. Here, because there's only 1 operation in a shop lot, and they can do 15 operations one day, 8 to 5, and every patient discharged within 1 hour after surgery, and the cost of surgery is only 103 ringgit, and the more you do, the better you are in terms of outcomes. And this is one center, although it's a shop lot, but it's overshine any hospital in this country doing cataract operation. And we do have performance monitoring in place using the electronic cumulative sum assessment, the indirect and indirect indicators to monitor the performance of our surgeon. And this is one example of how we can improve the quality of care when you continue to do the same operation in the community, especially when we talk about cataract surgery. Then also we embrace the concept of cluster. We do have district hospital, and we have 150 hospitals in the public sector. 50 hospital, we have specialists in 50 hospital. But more important, that 100 hospital, we do not have specialist services, only visiting. But now with the cluster services, and one hospital, main cluster hospital, the lead hospital, will provide the clinical specialty in the district hospital. And it is responsible of the respective department and also specialists to function equally in the district hospital. And that has actually improved the quality of care as well as utilization of and optimization of resources. More importantly is to work with partners. For example, working with Drug of Neglected Disease Initiative, find organization for diagnostic, and whereby we look into the access of medicine, for example. Hepatitis C medicine is very expensive, $300,000 for a 12-week treatment. How can we actually bring down the cost of medicine and access to our patient? We have 500,000 population here. We have hepatitis C, and we have actually came up with using the government right, for example, for HIV and hepatitis, bring down the cost of treatment of hepatitis C below $300, to be precise, $283. More importantly is when we look into it, this is just opening up the research-based or value-based research, looking into how can we improve further. Can we bring down the treatment to 12 weeks treatment to maybe 8 weeks or 6 weeks? It will cut costs to 50%. So high impact, reasonable cost, this is the initiative that we try to move on. But more importantly, working in partnership, whether locally, regionally, or globally, for the same cost to address the issue of access to medicine, access to services. And when we look into working with FINE, we believe that without proper diagnostic, practicing medicine is blind. So again, important for us to come up with diagnostic at point of care. So if we can bring diagnostic at point of care, which means we can bring treatment and even management of patients from the hospital and the clinic back to the community and home. So this is a concept that we would like to embrace, bringing the treatment back to the home. This is not new. Over the years, we have done it before, but we are going to revive it with precision medicine, using technology, using creative ideas, bringing healthcare to the home. So we believe that innovation and collaboration is important. And we have started pharmacy wear posts. Instead of patient coming to the hospital or clinic to collect the medicine, we are sending the medicine back to the patient through courier system at home. And they pay minimum less than $1, for example. Domiciliary care, how can we bring healthcare to the home? And we already have that concept in place. We also look into family doctor concept. But unfortunately, we're not able to do it because we are short of staff, doctors, and nurses. And for us to bring the doctor from the clinic to the home, we have to provide transport, provide a car, provide a driver, maintain the car, for example, and then we have to pay the petrol and toll, etc. So we are thinking of new ways of doing things. Is it possible for healthcare not to be employed by Ministry of Health, but register with the Ministry of Health, and we will give them the SOP, training, etc., but Uberization of the healthcare system. They do the call, they get the payment, and rather than salaried by the Ministry of Health. This is one concept that we would like to explore in time to come. And alternative birth center, we call it low-risk birth center. Those low-risk birth centers should not come to the hospital. There should be a maternity home, for example, near to the hospital, and improve the efficiency and the quality of the services for our patient. Now, at the present, what we have done for the last 10 years is look into the 8 thrusts of healthcare transformation to improve the quality of care. We do know the most important, prevention is better than cure, creating a healthy ecosystem towards a healthy lifestyle and disease prevention, particularly the NCDs, which include cancer treatment, which include mental health as well. So this is an ongoing, looking into the risk behavior, how can we empower our public to be responsible for their own health. Health is not only the responsibility of Ministry of Health, but health is the responsibility of every individual and family. So this is one of the trusts, and we have multiple programs under a healthy lifestyle. How can we use technology to empower our patients to monitor their health? So this is some of the initiatives being done in the Ministry of Health. Second, strengthening the role of the primary healthcare, because when we look into the involvement of healthcare over the years, over the 61 years of independence, we can see that initially our focus was only have the basic services and focusing on maternal and child health and communicable diseases. But now the NCD and aging population is coming into our spectrum of healthcare. How can we improve it further? So we have started in the pilot, the 20 of a hospital, looking into enhanced primary care, whereby we believe that better engagement of patients, patient comes to the clinic, seeing the same doctor and same team will translate into better quality of services. And can we also look into healthcare, bringing from the clinic back to the home? So this is a concept of strengthening the primary healthcare. And we hope that by doing so, in time, we'll have a better diabetic control. And diabetes, for example, in NCDs in this country, we have increased, over the last 30 years, the incidence have increased from 6.6 to 17.5%. More importantly, 50% of our population do not even know that they have diabetes. And those 50% who have been diagnosed diabetes poorly control although on treatment. So this is a challenge that we have. How can we improve the quality of care? Perhaps improvement of engagement and communication and explanation of the disease will have a better outcome in time. So we look forward to see what the implementation of this primary healthcare, enhanced primary healthcare in our system. And in any organization, it's important for us to look into the asset of the human resource, and this is the most important asset in any organization. So we continue to train our doctors, our specialists, using the local training program, and also now we have partner alternative pathway using the parallel pathway from the UK colleges and with training, and we have so far we have 14 discipline specialty working closely with the UK colleges for training. And optimization of the healthcare resources, as I mentioned earlier, cluster hospital, lean hospital approach, addressing the congestion in our hospital. How can we bring healthcare to the patients, and that will decongest our hospital as well. So we are open to creative ideas and innovation, and using technology will certainly help us to improve the quality of care at home. And healthcare system delivery and work process, we need to re-look back again our healthcare system. Some of the system and processes are already obsolete, but we still practice it. So can we, for example, look into innovation, make complex operation, innovate complex surgery, complex approach procedures, make easy to simple operation. Rather than simple operation made difficult using robotic, using etc., more cost and different pathway of doing things, and that will complicate matters worse. Then we need to embrace ICT. Today, because ICT with big data management, because with our limited resources, we know exactly where to spend our money and basically to improve our quality of care. So we address precisely, rather than carpet bombing, for example, the issues and challenges needed be, and because this must be based on data. And also today we are looking into the system, ICT, the clinic, the hospital, how can we integrate the clinic and hospital, the information system. Next is using AI technology. AI technology will change the landscape of how we deliver the healthcare system. For example, I was shown some of the AI in the market using AI technology for mammogram reporting. And they have shown that, for example, you have a mammogram microcalcification, and you highlight the area of microcalcification. It gives you the accuracy of 95% that this is a cancer, for example. So you do not need a radiologist to report it now, and AI technology is able to do so. And they have done a study looking into the AI and looking into reporting from the radiologists, and they found that AI technology is 6 times more accurate than the radiologists reporting the mammogram. And more importantly, with this technology, AI going to be disrupt the whole system of how we deliver healthcare. Perhaps you don't need a teleconferencing anymore if you have AI system in your computer, for example. So this is coming, and we hope that once we have integrated the data and big data management, AI technology will be the norm of the day. And we look into public and private integrations. And this is important because the government sometimes is very apprehensive to invest on technology that has not been proven, but sometimes championed by the private sector, and we work together, integrate with the private sector, bringing together the whole ecosystem of transformation to improve the quality of care. Last but not least, and we are looking into this, very important component is the social health insurance. How can we maximize the utilization of resources, not only in the public sector, but public and the private sector? So for example, in Penang Island, one island, we have 5 PET CT scans in a private hospital and 1 in the public. Obviously, 1 in the public will over-congested with patients, but the 5 in the private sector underutilized. They only run the services once a week, and there will be no return on investment unless we can integrate the public and private sector together, maximize utilization of the resources, the equipment, the human resource, and be sure that we can balance in terms of better outcomes for the healthcare in this country. But to do so, we need to bridge who is going to pay. And this is where social insurance comes in. And we've been talking about social and healthcare insurance for the last 33 years, but we continue to talk. But we hope that this next 5 years, we are able to implement. These are some of the mega trends changing the world with disruption. One is urbanization. 80% of the population will be living in urban area. And we do have challenges when you have living in the urban area, very congested population, infectious diseases, and how do we deliver healthcare in this urban population. And we do know that stunted growth also happens in the urban population, not only in the rural area. So although in the past we have been focusing in the rural area, but it is time for us to reshape our healthcare system to cater for urban population as well. All the challenges, issues and challenges in the urban area. Aging population, in 2030, 15% of population in Malaysia will be in aging population. Are we ready to cater for this change in our landscape and of healthcare? And if they have increment of 20 years, the burden is on the public sector. And we do know 50% of population aged 60 and above have 2 comorbidities, hypertension and diabetes, for example. When they reach 70, 50% of them have 3 comorbidities. And that is actually an impact on the healthcare resources. And we are only spending 4.5% of our GDP for healthcare. More so in the public sector, it's only 2.3%. So with the limited resources that we have, how can we maximize the outcome, maximize the quality of care, and can we do it to make a big difference in healthcare in time? Looking at digitization, we believe this is the way forward, and we believe that this can cut costs and this can improve the quality of care of our services. And resource limitations, limited resources, for example, overpopulation, we are looking into energy, food, water supply, etc. So we also need to look in the geopolitical shift, the rapid growth of emerging markets, and creating a new world order by 2050, for example. And the change, society change, for example, tension between globalization with tendency towards nationalist protection and trade agreement, etc. All these will have an impact directly or indirectly to our healthcare system. Now, these are some of the things that we need to embrace in time at present or for the future. One is looking at telemedicine. We believe that telemedicine market is on a constant rise, and over 7 billion patients are expected to access to telehealth services by the year 2018. And whether we like it or not, this is coming. Secondly is a personalized treatment, precision medicine. Genomics and advanced analytics are paving the way to fight unique diseases with personalized medicine. So, and third, using artificial intelligence, as what mentioned earlier. And fourth, wearables. Now we have the wearables. And fifth is mobility and cloud access. How can we use this kind of technology? The technology is there in piecemeal, but more important for the government is to look into the framework, incorporating all this technology in our hospital, in our clinic. And using this framework, can we set a new platform, bringing healthcare from the hospital and the home and the clinic back to the home? This is a challenge with precision medicine, customized medicine, for example. This is, again, embracing the system of Uberization, which we want to do it in time. Now, when we focus in the healthcare back to the communities and the families, this is giving good quality of care to our patients in their home. Second is prevention is better than cure, focusing on quality lifestyle and rather than curative, focus more on prevention, healthy lifestyle, healthy eating, etc. Make available healthy food, for example. Today, healthy food is very expensive food. Can we make it, reverse it? Healthy food, yeah, the cheap food, not the junk food. And healthcare will be driven by quality of care. And we need to define what is quality of care and have a common benchmarking of quality. And more importantly, simplify healthcare using creative innovation and smart solution, not the other way around. Making simple procedures, simple approach more complex. So we need to redefine and simplify the healthcare. Public and private integration along the change of our healthcare is equally important. It's part of the strategic planning. That is actually the principle of delivering our healthcare and transforming our healthcare for today and tomorrow. Now, the Uberization of the healthcare system, the concept is there. Can we embrace this concept? Have a digital platform, providers, healthcare organization, and IT system comes together to provide this platform. And we provide services at home. And on the other hand, we regulate in terms of fitness of practice and etc. Registration of the providers, and we know who is where, who is who, how are they treating patients, etc. Looking into 5 guiding principles. Patient safety must come first. Second, looking into quality of services. If the quality of services is not at par, for example, if they provide healthcare services to the home and the family is happy with the services, they can rate the patient, rate the provider, or rate the doctor 5-star. If they're not happy with the doctor, probably they rate the doctor 1-star, and we can terminate the doctor straight away, for example, from providing healthcare. But if they give 3-star, we'll call the doctor for viva, for example, right, to see how can we improve further the quality of care at home. And as such, we'll develop the family doctor concept. And this is where I think taking healthcare to the home is the future. And looking to confidentiality, when we use IT, we use electronic healthcare system, electronic medical records, we need to look into security and confidentiality of the medical records. But more importantly, whatever been written, for example, going to the home, and they'll plug the patients and all the history goes to the iCloud. Ministry of Health will be responsible to iCloud. When they do the clinical examination using the latest technology, stethoscope, for example, electronic stethoscope, then it will tell you a systolic murmur or diastolic murmur, and also the stethoscope that we have can also tell you the first heart sound, how many milliseconds, second heart sound, how many milliseconds. And these are the precision medicine that we can use. They can also bring the point of testing, for example, they need to do imaging, ultrasound. You have a mobile ultrasound now using your handphone again. And what about a point of testing, diagnostic? You can actually do it at point of care at home using the diagnostic. So these are some of the things that we hope that we can able to deliver the whole ecosystem of healthcare service to the home, which is accountable and traceable. And for a start, we have already been doing this over the years. Physical services, we have a mobile team, we have flying doctor services, we have boat services taking healthcare to the community. But what about when we use the virtual? Can we have a physical and virtual services in place? For example, today, I operate on my patient and I discharge my patient. Follow-up, basically, patient have actually the access to me in terms of communication, whether it's virtually or even texting me. If anything goes wrong with the patient, I always tell them, let me be the first person to be informed, and I'll tell you what to do. For example, this is a personalized care, and perhaps that will give confidence to the patient because they can access to the doctor anytime, although not physically, but virtually. But again, in future, can we look into the virtual healthcare services that we're going to explore? But we need to look into various acts and regulation that hamper the progress and facilitate the virtual services currently. And the Malaysia digital health landscape, you can see that the premium services is already available in the private sector. The premium home visit, for example, home nursing and aging care is all available in the private sector, especially second opinion, taking healthcare to the home. Now, how can we embrace this from the private sector into the public sector? So working together with actually a few of these private company, perhaps to enhance it in terms of duplication, avoid duplication, and then probably using the whole system to increase the efficiency in the public sector. Now, healthcare to you through smart public-private partnership. Professional home care is an enabler of continued management of care in a home setting. That is the best. The best bed is actually at home, not in the hospital. The best food is at home, not in the hospital. So can we use the home environment for home care, home treatment, and etc.? Next is to relieve the patient and family from many challenges in seeking care from the healthcare facilities. Coming to the hospital, for example, and you have issues of congestion. Parking is a big issue. Waiting time is a big issue. And can we look into fragmentation of these services in the hospital back to the community? Home care packages, for example, can we have chemotherapy at home, palliative care at home? Can we have wound care at home? And these are some of the concepts that, endless possibility, but do not compromise quality of care. And there must be a proper monitoring process in place, and also the feedback from our patients. So this is some of the benefit that we think the client, probably the elderly patient, post-op patient, stroke patient, and or fall, they have a difficulty coming to the hospital, long-term care, reduced mobility, and all this actually will benefit the patient at home. Second is look into healthcare providers. We can employ our doctors going to the home, we can employ our healthcare workers, but we also can actually independent contractor, open it up for Uberization. Those registered with us, whether from the public sector or private sector, and we give them the training, we give them the equipment, and with that, when there's a call at home, they can actually service the call and get paid. This is whether it's a full payment or co-payment that we can discuss the whole idea of system to create a new ecosystem of healthcare at home. And the benefit will be reduced costs, reduced reduced time, length of stay, and also congestion in the hospital. And this must be patient-centric. So we are moving towards healthcare, towards patient-centric and research, patient-centered research, patient-centered services, and etc. So that we believe will be the future, and it's convenient, comfort, and then also we can create a job creation here. And for example, if one doctor goes to the home, get paid $100 US. If they do 10 homes a day, already they make $1,000 US. And $1,000 US per month, probably they are making $30,000 US. That is better than my salary, for example. So this is one of the concepts that we think that is a potential for us to develop using the digital economy, digital platform to transform healthcare to better quality of care in time to come. So healthcare to you is the framework. When we look into the service delivery, how can we provide in terms of the traditional mobile services that are already in place, looking into some point of care of testing. Is it possible for today, for example, when we look into urine pregnancy tests, 30 years ago you had to see a doctor to confirm whether you're pregnant or not and collect your urine and send to the pathology. The next day you get the result. Today you don't have to, you can do it at home. Is it possible for other tests? Because we realize that 30 tests are available now for to be used at home in community. For example, you can do point-of-care testing for dengue. Is it possible for us that the patient have access to this test at home? So if they have fever, they can test themselves whether they have dengue or not. Is it possible for us to look into the point of care for HIV, for hepatitis C, and salmonella typhoid, and all the 30 diseases that you can do it at home rather than coming to hospital? Can we empower our patient in time coming to the doctor for second opinion? It's not coming for a doctor for consultation, but second opinion. Because today, patient comes to the hospital with all the information in, and they have read all this information from the internet, from Google, and etc. And sometimes they're questioning the doctor whether they have the same knowledge of technology. And I'm worried sometimes from my house officers and junior medical officer, and when the patient is smarter than the doctor. So I always tell them, if you do not, know the answers, excuse yourself, go to the toilet and start Googling, right? And probably you get the information and come back and then to explain to the patient. So that's, forget, smart way of doing things, right? But that's today. But what about the future? The future, the patient will come to you. Some of my patients today comes to me with all the investigation. They know the reports. They just want to see how are you going to interpret it. That means they are coming to you for second opinion. So things are going to change. The platform of how we deliver healthcare will change. What about in future if they have AI? If the AI in place, they have the reporting and everything. So they come to you for second or even third opinion. So that is the scenario of healthcare going to disrupt the way we practice medicine in time to come. What about prescription? Once you examine the patient at home, then you have done the investigation, then you need to prescribe. You can have online prescription. And once you have online prescription, the pharmacies will have online dispensing. The nearest pharmacies will dispense within a KPI of 3 hours, for example. The medicine will arrive at home. So this is another totally a different ecosystem which is possible. And I'm sure if there's the demand from the public, demand for the patients for have this kind of services at home, why come to us for treatment in a hospital and clinic when the services can be delivered to you at home and your own environment? So that would be the ideal approach, because that will create a family doctor concept, whether it's virtually or physically. Now, some of the innovation that we have in place, this is where we need to open up our young, dynamic innovators looking into various innovation that is make complex procedures or protocol to simple. For example, urine dipstick. This urine dipstick, you only need a reader, and once you insert the urine dipstick into the reader, within 1 minute, they can tell you 10 parameters, RBC, urobilinogen, uric acid, etc., at point of care. And again, blood tests, Abbott have come up with this diagnostic in terms of screening the blood. For diabetic patient, before any meal is screened, you just scan through the patch and then you can read. You don't need to do lancet anymore to actually prick your blood and to test it. But unfortunately, it's only for 2 weeks. Now we are exploring technology, whether it can be 3 months, whether it can be implanted for more than a year. If that is so, if you have accurate diagnostic of blood sugar, if your blood sugar is low, then why pop in the tablets? Why take medication? Because you go to hypoglycemia. But if the blood sugar is low, then you have a trending. You can see the trending of the day, and you can eat more. But if your blood sugar is high, then you take a medication. Again, precision medicine using diagnostic. Without diagnostic, practicing medicine is blind. And again, ultrasound. I mean, ultrasound now is in your pocket. This is actually ultrasound, very expensive equipment, and it basically now we have, you can use your iPad, you can use your iPhone. I just got my ultrasound, using my handphone and iPad last week, and I've been practicing. Very convenient for me to have my ultrasound in my pocket, and it's just like a very important tool. And this may, in future, perhaps all doctors will have an ultrasound machine in their pocket. And providing the home care, you can bring this ultrasound machine as well. And we look into the technology using stethoscope, smart stethoscope, and also using your handphone for otoscope and transcutaneous electrical nerve stimulation for pain management using a wireless patch, and you can control with the handphone. All this technology is in place. The question is, how can we use all this piecemeal technology into a framework of healthcare system? And this is where if we have the framework and we continue to develop technology to improve the quality of technology. We have wearables, we have wristband, most of you have an Apple Watch, you can actually have the monitoring system, pulse rate, ECG, and etc. But now I think we also have a smart health from the waist. You can measure your eating habits, your waist, your steps, your sitting, etc. All this already in the market. And this is the e-stethoscope I'm talking about, and made in Penang. This is one of the important tools that we've evolved the healthcare in terms of how we practice it, because not only this is a stethoscope to diagnose systolic murmur and diastolic murmur, you don't need a cardiologist to do so. Even a schoolboy can use this, and you can, more importantly, is also a biometric identification for each and every one of us, because each and every one of us have a different heart sound, first heart sound, second heart sound, measured in milliseconds. So with that, you can actually identify a person. And also, for example, looking into this physiotherapist machine, it's also equally important that you don't need a physiotherapist to do so. You can have this, and you continue to develop all these services. Once you have the tool, then you need clinical research for to look into the clinical practice, how best we can improve this quality of care. And the framework, this is the important, as a government, looking into the framework formation of the telemedicine group, or we call that digital health. We have 4 SIGs, special interest group. The first is looking into policy and regulatory. Some of our act already obsolete because it's been our act has been created way back in 1970s, whereby we don't have technology, ICT in place. So we need to re-look back again in terms of policy and regulatory. How can we amend or even improve to facilitate ICT development? Second, knowledge dissemination. Have a platform of networking to encourage the junior to come up with a competition, for example, award them, appreciate them in terms of areas of development and IT. And this is where we realize that there's a gap between the medical fraternity and the medical industry, particularly in this country. The medical fraternity have lots of ideas, but they do not know how to do it. But the medical industry, for example, electronic industry, they have 40 years experience, but they do not know what the doctors need and want, for example. So now we have to integrate the two healthcare providers, for example, the medical fraternity and medical industry together, one platform to come up with innovation and creative ideas. And then perhaps by doing so, they can come up with a lot of innovation and create a whole ecosystem for us to continue to embrace innovation in our system. Once you have the tool or you have created innovation in terms of the devices, more important is to do a clinical trial to see the cost effectiveness of using the equipment, and how do we upskill from the idea into the marketplace. Here you need the investment, not only the medical providers or medical industry, you need the bankers, you need the investors to come in to see how can we share and grow this market of clinical innovation. Ladies and gentlemen, it is not the strongest, the species that will survive, nor the most intelligent of us today here, but it is the one that most adaptable and responsive to change. And the change that we have is information technology. Whether we like it or not, we need to embrace technology in our medical services, otherwise we will be obsolete in time. And I would like to end with this tagline from Ministry of Health. Our tagline in the Ministry of Health basically is a nation working together for better health, public sector and private sector coming together as one, and we believe that every sector is indeed a healthcare sector. With that, ladies and gentlemen, thank you for your attention.
Datuk, thank you so much for a brilliant presentation on your own passion and the passion of your department here in Malaysia. It's no wonder that we recognise you as world leaders, and we need to recognise the value of leadership comes from individuals. We've had a wonderful morning. It's all been about leadership, really. We've seen the passion of Peter Carter, for which he got his award. We've seen the passion of Sandra as she shared her own experiences, and we've seen the passion of the Director General as he's led as a servant and as a leader, as a clinician and as a manager, his country to the highest of places. We've got something to take out into morning tea to talk about how this impacts upon us and recognise it's up for us to follow their example. But would you put your hands together to thank the Director General in particular for his address? That ends this session. Can I remind you to use the app to evaluate it, use the app to work out where you've got to go next, but enjoy your break. Thank you very much.